Michelle, and thank everybody for being here. It is nice to see some people that are not our members, that they're coming from other parts of the country. So welcome everyone. I'm going to share my screen. I think you've all been doing this for, I don't know what, a year and a half now? The screen sharing and all of the above. Everybody see the screen? Hello?
Yes, yes,
okay.
Absolutely.
All right, great. So thank you, AAPA, for the opportunity to present on one of my favorite subjects, conflict resolution. And many thanks to all of you again for joining this session. As Michelle said, I've been a mediator for 18 years and I've helped people resolve all kinds of disputes, you name it, and I've done it. I even went to dog court one time, believe it or not. It was a legitimate thing in LA. And conflict is normal in life. An important thing to remember about it is it's the participant's problem and it's up to them to figure out the solution, but sometimes they just need a little help. Our role as a peacemaker is to help them get unstuck and to move forward in their life. As an advocate or family member of a patient, we are sometimes asked to attend family meetings. The meeting is usually requested by the medical staff to discuss a treatment option or some other issue, and the meetings can often be contentious. There's a lot of a mistrust on either side sometimes. So how do we, as patient advocates, navigate the choppy waters as a participant or a peacemaker and guide the disputing parties in helping themselves get the medical answers they all need? Well, mediation is one way. The short definition of mediation is it's a process of shaping shared solutions. The long definition is it's a confidential and voluntary process where an independent and impartial third person empowers the participants. There's empowers, meaning so they can find their own solution, to find a mutually acceptable solution that meets their interests and needs. The mediator is not a judge and does not impose solutions on the parties. If the goal is to make a decision about a treatment option or resolve a conflict among staff and family, one way to achieve it is through mediation. It's been used for many, many years in a clinical setting. It's different. All mediation types are different, but bioethics or clinical mediation is in a kind of in a class by itself. Studies show that the biggest source of conflict in an ICU is among family members. And I can't see you all, but if you're a nurse or a doctor and have been in a clinical setting, I think you can probably agree that's true. Conflict often begins when families disagree about the goals of care, withdrawing life support at the hospital, or individual caregiving responsibilities among the family members themselves. Conflict often arises as a result of people witnessing a loved one suffering and anticipating their death. Okay, we are not. Sorry, my screen is not forwarding. Rick. I'm going to stop share and try it again. Screen share. It was working a minute ago. There we go. So many times the conflict is caused by stress because the people see their loved one suffering or dying, actually, and so conflict comes up. Often the disputes are rooted in childhood. Family dynamics play a huge part in the conflicts, and bad feelings from old hurts and slights don't improve when people age. They just get louder and more entrenched in their positions, and it creates stress and more anxiety for their dying loved one. One of the mediator's goals is to make sure everyone at the table not only has a voice, but is actually heard by the other parties. all within a safe setting. But is there a better method? And this is conciliation. It falls under the umbrella of dispute resolution, but it's quite different. It's shaping shared solutions with an added bonus. And the added bonus is mending relationships or keeping relationships on an even level. It's a process where a neutral third party, again, it's a neutral, encouraging disputing parties to discuss their differences, identify the issues in dispute, and improve their communication and explore possible solutions. A conciliator can be anyone with skills to facilitate a conversation, including a family member or staff. If the parties have to keep dealing with each other, conciliation can help as much as because it's as much about restoring relationship than resolving conflict. I have this chart on the differences, and really, they're both processes, but they are very, very different. Conciliation is less formal than mediation and more flexible. There's no strict ground rules, and location is typically in a hospital conference room, and that's not really where most people would consider it to be neutral ground. Ground rules set the tone and maintain order. And by the way, in either place, I only have two ground rules. One is don't speak when someone else is speaking, because I can't hear two people speak at the same time, and neither can other participants, and everybody gets their turn. And the other ground rule is silencing cell phones. It's hard to do in this setting because a lot of times doctors may be on call. So really the cell phone thing, as long as it's set to vibrate, that's probably as good as you're going to get. There's no agreement to mediate or formal opening statement, which are hallmarks in mediation. Conciliation is less about process and rules and more about trade-offs to reach a consensus. Mediation is voluntary. People are not forced to participate and can leave the room whenever they want. Parties can probably leave a family meeting, but the stakes are often high, such as deciding life or death issues, so leaving would be difficult. The mediator is neutral, an impartial participant, typically an outsider with no ties to either side. A conciliator can be someone from the family or hospital staff, such as a social worker or a chaplain, as long as they have the skills to facilitate the conversation. It's really all about conversation here. Mediation is always confidential. In conciliation, it may not be important or even possible. Not all decision makers may be in the room. A family member with considerable sway may be out of town. A neurologist, we may just have his report and he's not available. But both these parties and many others, such as the nurse on the case, may need to be consulted and informed about the discussion. So it's really almost impossible to have a conciliation that's that confidential. In mediation, there's a signed agreement. If the parties reach a resolution, and sometimes a court's involved, so it's pretty formal. In conciliation, there's usually just a commitment to act, such as putting in a feeding tube or trying another round of chemotherapy. There's no formal agreement for that. They just decide what they're going to do when they do it. In mediation, the goal is conflict resolution. In conciliation, restoring a trust or repairing a relationship is just as important as resolution. So why either process, really? Who can conciliation help in your world? There's a doctor, a hospice and palliative care doctor in Washington. He said, timely, well-conducted conversations about goals of care and serious illness are associated with improved outcomes, including care aligned with the ill person's wishes and values, less unwanted and expensive care, especially at end of life, improved satisfaction, and fewer mental health consequences for patients and families. So when you have the conversation, it turns out even if the person is terminal and they're going to die, the people involved in their life, it's a better I mean, the person's still dead, don't get me wrong, that's going to be sad for them, but it's not as stressful on other levels. So who can it help? Family meetings often arise from disputes about treatment. The dispute may be family versus provider, two clear camps, or it may be family member against provider, or the medical staff may be at odds with each other about treatment options. Conciliation can help the family and the client, especially in an emergent situation and the family needs to make a treatment decision ASAP. The family's stuck on being angry or are confused, not feeling heard by staff or feeling they don't care about the patient, but only about the saving money. Lack of trust in the medical system is huge. As you all know, families disagree with each other about the best care and best treatment option. Everybody thinks they know best. The family doesn't understand the medical jargon. That's huge. They can't seem to get straight answers, or they feel pushed to make a decision. The family has questions about withholding or withdrawing treatment. The next group that it can help is the medical staff. They have their own set of issues. The staff needs treatment decisions right away. Specialists disagree on treatment options, confusing each other and the family. They have ethical issues around futile or inappropriate treatment requests. Examples like dialysis for a patient in a persistent vegetative state. They're not going to survive. Why do they need a dialysis? But that's one of the things that happens. An ICU admission for a person with end-stage dementia. These types of things, the staff may consider it futile, so it's a problem for them, and they really need to sit down and talk about it. The moral distress among staff in dealing with this family and in this situation. Again, if there's distrust involved, people are not their best. Here's how it can help both groups. Communication between staff and family has either broken down or continues to be unproductive. So they have a meeting, nothing gets solved. Distrust and anger on both sides. No advance directive, or if there are directives, someone needs to interpret them to honor the patient's wishes. That's a pretty big one, seeing as only about 30% of the people in the United States have advance directives. A surrogate appears to be acting counter to the directives. So if a surrogate comes along and says they want this, that, or the other thing, or they don't, and the directive spells out exactly what the patient wants, that's an issue. So what is the big hurry in reaching a decision? Often there's a need for speed. What are the risks in waiting too long to make a decision? Is the loved one incapacitated or heading in that direction? The illness trajectory. Will the client or loved one get too sick or feeble, be in more pain if you wait? Family members are pushing for decisions. They may have different opinions about cares and goals of treatment. Mom wants everything. Mom would never want that. The long lost brother who swoops in to take control but knows nothing about mom's wishes. And I just talked to somebody yesterday whose ex-husband is on life support in a Phoenix hospital. His sister and siblings want them to do everything, and he has no advance directive, but he does have an adult daughter, and she knows he doesn't want everything. She had the conversation with him. So now there's sort of a what do we do now situation. If the hospital goes against the family, they could sue, and they're always worried about that. But really, legally, the eldest daughter has the right to make those decisions. And I don't know where they're at right now, but they were supposed to put in a feeding tube and a trach yesterday, and she didn't want either one of those things. So stay tuned. I will find out this week. So those are family members, and there you can see that's why there's dispute in an ICU. Planning the next steps. There's a hurry because if these people are transitioning to long-term care or going home with hospice, they have to figure out which sibling will be the caretaker or child or hire additional support. You need to make plans. The loved one choices. What does the patient want? There's a duty to respect their autonomy, their values, and their goals of care. And informed decision-making. Info sharing from the staff is the medical condition of the patient, client, and the options about what to do or what not to do. And the info shared by the family are the goals and values of the patient before the illness, the incapacity, decisions about end-of-life care, such as hospice or discharging. What is it exactly that they want? Getting on the same page about patients' treatments. That's the big hurry. Here's some peacemaker approaches, and I love this slide. The picture, it's a guy from California, and I've had this picture for many, many years. He gave me permission to use it, and that's sometimes how it feels, like you're a little mouse in the middle and these people are, ready to pounce. Here's some approaches. Always remain neutral. If you show any bias, you undo the trust you might have established. And that might be difficult to do if you're a family member and you're a conciliator in a family meeting, but do your best to try to stay neutral. The parties will turn off if you don't, instead of tuning in, which is what you want them to do. Bring your passion and enthusiasm to help solve the dilemma. It gives the parties motivation to work towards that goal. Not be peppy and cheery, but be enthusiastic that you are going to resolve this. Encourage someone to express their feelings. Feelings lurk in the background, and if you validate them, it can open up a log jam and let the person see another person's point of view. Be curious about the situation and everyone's perspective. I use the word curious a lot in mediation, and it's, like I'm a professional snoop, actually. I get to ask questions that other people don't get to ask. And I'm not being snoopy, I'm just trying to get to the bottom of things. But don't try to figure out someone else's motives, because if they suspect you're doing that, then you lose their trust again. A lot of times it's all about trust. Assume all the parties present have the best motives and intent. Your techniques must be genuine, or they may have a negative effect. You need to show respect for the patient and the patient autonomy by finding and following the views of the person who can speak best for the patient, a surrogate or a family member. You need to find out if they've had the conversation and what it is they want. That's why it's important to have all of the stakeholders in the room. Here's a conflict management model, kind of a quick and dirty dispute resolution model. Caution everyone there to suspend judgment or blame. And people come into the room and they're angry and they're upset and they don't trust anybody, remind them, everybody's there to help the patient and to suspend all your judgment and blame. Figure out the issues by asking questions. Ask parties for their input. Both sides have something to contribute. Once everyone is heard, brainstorm options for settlement or decision-making, and then agree on a plan of action. And this is what you don't do on the picture on the right, and this is why we have constant conflict disputes, because people do blame, and it's a vicious cycle, and you want to try to break that cycle. Here is like sort of a Rube Goldberg method to clinical family meetings, and it looks crazy, but there's always a method to the madness, and it's called process. Here are the steps in a clinical family meeting. I mean, if you've been through them before, I apologize, but this is from Mediator standpoint. Planning is not just about the welcome. It includes prior staff meetings to make sure they're on the same page to whatever the medical facts are and the meeting goals. Then everybody welcomes and introduces themselves as either a family member or a staff member. I mean, how they fit, what the goals of the meeting are, and acknowledge the topics or issues. Explain that the topics may be unsettling or challenging. Sometimes these are life and death issues, and of course it's going to be upsetting. Check that each family member understands the illness and the patient's prognosis. If they're all coming from a different place on what's happening with mom, then you want to make sure that they all understand what's really going on. Listen intently, completely, always be present and in the moment. Your goal is to create a safe space for these people so they can have an open dialogue. Check for consensus about current goals of care and symptom management. I mean, how's all that going? Are they aware of a timeline or a level of suffering? You really kind of want to know that. And again, remind them the goal is, everyone's goal, everyone in the room is to help the patient. Do what's best for the patient. Three is identify a view of the future and the concerns about treatment options, and have the staff clarify what each option will mean in the patient's care and what the future holds, how the family feels about that based on an option they choose, or by inaction by choosing no treatment. And sometimes choosing no treatment is the best thing going. Like the guy I was just talking about with a trach, he's been in a coma for 2 weeks. I don't expect him to survive. And now he's got a feeding tube and a trach. Is that like really what he wanted? Ask family members how they're coping and feeling emotionally. Embrace the emotions, that's big. Help them acknowledge their worst fears. When you put the fears out in the open, it helps them deal with them. And don't push them in any of these meetings. Give them the power to set the pace. Lack of control is huge. Setting the pace gives a little control back. And remember, if somebody keeps repeating themselves, they've told the story and then they tell the story again 5 more times, that means they haven't been heard. So your job is to really summarize what they've said, so at least they know you understood it. And 5, summarizing helps keep the conversation on track and gives a voice to the most important issues at hand. It lets the person know you heard it and you've got it. Be succinct while trying not to miss anything. Spell out the decisions that were made. And I repeat this again, be succinct and ask them, did I get everything? Wish I had $1 for every time I said that. Resolution and action plan. Decide on a course of action and who will do what when. How will the family know about any outcome? Name a key contact person in the staff and the family so that they can let other people know what's happening. What if the treatment doesn't work? Or what if the decision is not what you expected? Is there a plan B? Acknowledge uncertainty and unknowns and never make any promises. So what if there is no resolution? Not making a decision is the same as making a decision. So things would continue in the status quo. And here is, this part of the presentation is really about how to resolve the dispute, where you start, what is the starting point? And the starting point is with the iceberg. This is pretty famous in my world. In any dispute resolution process, you have to start by separating the people from the problem. You do that by separating the positions from the interests, always looking for reasons beneath the position. Much like the iceberg, there are things above the surface that show themselves called demands. Then there is all that's going on underneath, or what they want, which are called interests. And finally, at the very bottom, they're the must-haves. They need to get this in order to feel satisfied. So here's a chart of positions versus interests. And a position is a demand or assertion. These are just, pulled out of a hat. I want a new doctor. So somebody comes in and says, I want a new doctor. Okay, well, that's the position. And so what's the interest underlying it? Well, the doctor doesn't listen, or he's arrogant, or the person is frustrated because no matter how many times she tells the doctor what she wants, he just doesn't listen. So I think you can see that, you know, these are, whatever it is on the left, it's a demand, you know, I won't call until you apologize. I mean, you've all heard them, but what's going on under the surface? They're hurt about something. They're angry about something. They're looking for respect or consideration. These are the interests. So when you know and understand their interests, it helps open the conversation for potential solutions. I'm going to go back to that one. Feelings, emotion, respect are always at the core of what their interests are. And fear is a very big motivator. You can see it's here twice, and these are just samples. Let them work through their reasons why they're upset with open-ended questions, not yes or no. Try not to ask any yes or no questions, because these open-ended questions are designed to make them think, to elaborate what's really going on. An example of an open-ended question: help me understand what bothers you about this situation, and then let them answer. And understand different positions can have shared interests. So uncovering shared interests will help find shared solutions. In a family meeting, two members may disagree about treatment options, but they have this shared interest in doing what's best for mom and not seeing mom suffer anymore. So maybe they can work together to reach a consensus for mom. And so my poor guy in the ICU, if they had a meeting such as this, they could sit down, and they both really love this person. There's no question about that. But one side wants to keep him around forever and not listen to the daughter. So their shared solution, maybe they can come up with something. Well, if he doesn't get better in a week or 2 weeks, maybe we think about comfort care, that kind of thing. You know, like, if you're all on the same page about loving this person and wanting to do the best, then hopefully you can find a solution. So how do you listen to understand? First, you pay attention when someone is speaking, you gather information, you turn to the person, you lean in, you make them feel like they're the only person in the world and what they're saying is so important. You don't interrupt. You listen to with your body and theirs. Body language, they say, is about 80% of conversation, really. So what they're saying with their body is as important as what they're saying with their mouth. If you don't understand something, ask a clarifying question. If there's a third party involved, so you're asking for clarification for that party as well, like in a meeting. Ask open-ended questions, listen for feelings and validate them. Again, I think, how many times have I said that? 2 or 3. Feelings are most important in difficult conversation, and they're very powerful when you validate them. Summarized, again, another word I've used, to let people know you're listening to them, heard what they said, and you really do get it. Acknowledge and accept what they have said, or, if you agree, or you can offer feedback if it's appropriate. So in a nutshell, listen, gather info to understand, clarify what you don't understand, reframe back to them what you think you heard, validate emotions, summarize, and finally, accept and respond. This is a little chart about difficult clinical encounters. And the 3 components or areas of difficulty are situational, physician characteristics, or patient characteristics. I could say patient or family in this case. So situations are the circumstances around the situation: language barriers, cultural differences, lack of privacy, too many people in the room, meeting location, atmosphere. It's not neutral. It's whose home turf is this? Enemy territory, lack of sleep. These are all situational issues. The physician or staff characteristic, is there paternalism going on? I think, we're all patient advocates. We know that doctors still, to this day, think they know best. I run across it all the time. They don't want to listen to an advance directive because they know best. Who knows more about the patient family, physician? Impatient, there are impatience. Are there time constraints in terms of dealing with the need for decision-making or in time spent with this one patient or family? And that's always an issue. You always feel like sometimes you're getting the bum's rush from a doctor, like, looking at their watch and studying their computer. I mean, that happens. The patient or client characteristics, they're angry or defensive, terrified, grieving, controlling, confused, frustrated. All of the emotions are there, and all of them can be there at the same time. How do you deal with power imbalances in the room? And I said before, like, first of all, it's not neutral territory. It's a family being in a sterile atmosphere of the physician's choosing. So how do families and staff too come into the room? At their best, probably not. Are they experiencing fear, frustration, grief? What, if anything, can we do? You try to meet them where they are. Accept their sadness, anger, hesitation, frustration, and don't try to cheer them up. How do we balance the power? You acknowledge the power imbalance. You bring it right out into the open. You have a conversation about it. Help them see what power they do have, and I'm talking about the family here, and you try to level the playing field, because ultimately it's the patient or the family they're the decision makers, not the staff. They're the ones that make the decision, so they have the ultimate power. How do we empower them? You give them choices, such as setting an agenda so they have some control. How do we shift from the uneven power to participant issues? Well, you say I assume everyone is here in good faith to discuss the issues and try to resolve them. People are more apt to open up about their issues when they feel everyone is there to resolve the issues in good faith. They need this process to be fair and open. What are our options about dealing with imbalance? Knowledge is power. Do your homework before you get in the room. Know the issues, know something about the participants, know the areas of commonality between the staff and the family, know the areas of where education might be in order. The more they know and are prepared, the more you know and are prepared, the smoother this meeting will go. And areas of education, it could be, these people think CPR is going to save a person's life 100% of the time, and really it's 1 or 2%. And what it does to elderly people, it can break their bones, their sternum. I mean, they might need some education if they want a full code, and the doctors are saying, like, that's probably, if the people haven't been educated about what CPR actually looks like, this is a time to actually show them or talk about it. Your job is to level the playing field and assure a fair process. I am checking, time check. Okay, failure to communicate. In the Paul Newman movie, Cool Hand Luke, which I love, there's a great line, what we got here is failure to communicate. And there's a link at the bottom of the screen. You can see a 2-minute, and it's always nice to watch Paul Newman for 2 minutes, even if he is getting beat up. In most disputes, it's this failure to communicate that is at the heart of the problem. In a family meeting, there are common communication issues like medical jargon. Second language to anybody in the medical field, but families don't understand medical jargon most of the time. Ask, and your job as the conciliator is to ask to translate. Could you translate what ICU means, just to use an example, so that the family can, so I can understand, and that lets the family know, like sometimes they're too intimidated to ask the question. They don't know what the hell's going on, and you being the neutral in the room, you can ask the question. So they get an answer without even having to ask the question. The amount of information is sometimes very overwhelming, spoken too fast, like me today with this presentation, because there's really a lot to get in. And so you want to really slow them down. Just people need time to think, they need time to process. This is like so important to a family, a decision, any kind of decision like this. So you need the time to allow them to ask questions. And they need time to process. You don't want them to feel rushed. You want to pick a quiet, comfortable setting, like location issues. I said that before, are sometimes a problem. You want to pick a quiet place, a conference room where everybody can sit and have a discussion. Be culturally aware. Is there a need to bring in a translator? You may have to do that. There could be some cultural issues, and culture in a hospital setting is also pretty huge. Discourage the use of metaphors like fight and battle illness, like studies show that really that's not a good thing. It sets an adversarial tone, and outcomes are seen as victory and defeat, and that's an issue. Euphemism, also problematic. Doctors never want to say a patient is dying because they see themselves as failing. So it sends a confusing message to the family. In one case, a doctor did not tell a woman about her husband's imminent death. So she continued to hold unrealistic expectations, expecting him to live another 6 months. Guess what? He died like several hours later. And she said, based on what the doctors were telling her, she thought he had 6 months rather than less than a day. So you need to spell it out, talk in English. Tell them what to expect so that they can make their own decisions and plans. Here's some common reactions to bad news. I'm sure you've seen all of these. People often have unrealistic expectations as to a cure or return of function. It's up to the medical team to educate them as far as prognosis. And if the news comes at end of life, anticipatory grief is huge. And it's the elephant in the room. There's my elephant. It's anticipatory grief is defined as grief that occurs prior to a death, in contrast to grief after death. And this type of grief, it's as real as the other kind. It's a loss of companionship, changing roles in the family, fear of financial changes, and a loss of what could be. And don't underestimate how this affects them. There can be lots of sadness, loneliness, depression, anger, and fear is usually at the base, fear of what's going to happen. So people don't really operate the best in this state. And this is from the hospice doctor's widow. She was married to a hospice doctor and he died, and she kept a journal, and it's really, I mean, it's such an interesting book. She said like 40% of widows said it was anticipatory grief was worse than the grief after death. I mean, if you can believe that. So they fear a lot of things, being alone and loss of their social work, social life, it turns their world upside down. What do you do when you recognize it? You honor the feelings and allow the emotions that come with it. Be patient with the person who's suffering and recognize it, really. Everyone deals with grief differently and have different emotions. One person may not be affected while the other one is obviously grieving. So you keep the lines of communication open. This is really kind of what's happening is they try to maintain hope, but you know, in their head, they know there's no hope. So it's kind of a tightrope. And I think people really do not ever give up hope. They're always hoping right up until the last second of breath that there's going to be something that helps bring their loved one back. How do you de-escalate anger and hostility. And believe me, it can be in the room, and it's tough to deal with it. You feel like it's directed at you. You just pay attention, you let them go, you let them talk, you listen, be curious again, be curious, acknowledge how difficult all of this is. This may be the only time these people have been allowed to vent. The family may just say, you know, we don't want to hear it. So here they are in a room with a group of people, and now they can actually say what's bothering them. And I think if you can listen to them and identify what they're really concerned about or they fear, once they get past that anger, you summarize again, got to summarize, you look for areas of agreement about what's happening. And once they're calm, you can move on and you focus on the future. That's how you do it. My just shut up and just listen. So when somebody is talking and, you know, there's like a pause, do you leap to fill the pause? A lot of people do. It's human nature. What do you do with the silence? Or when to shut up and just listen? It's the theme of Moshe Cohen's listening triangle. And Moshe was my first mediation. He was really a mentor. I took a class and then I took another class where he mentored me in real life courtroom situations. And he would say, just shut up. It's not about you or what you think, it's about them. So let them talk. Your job is to listen and learn. And as a result, I don't say much in a mediation. I let them do the talking. I do an opening statement. I tell them the 2 ground rules and let them carry on from there. Sometimes I have to, you know, remind people not to talk at the same time, but you value the silence. You ask the question and you listen for interests, and then you let them talk, and then you reflect back. It's a process again. It's how it's done. Listening, listening, listening. And speaking of listening, here's some ways to become a better listener. And don't you love this dog? Concentrate. No interrupting, no finishing other people's sentences. Isn't that annoying when you're talking and someone finishes the sentence for you? It's a waste of time and it's frustrating for the speaker. No distraction, shut off the phone, be present. Your total focus is on the speaker and on their words and meaning. Actively listen with your whole body, lean in, watch their body language. Don't jump to any conclusions or be thinking about your reply, just keep listening. How many times have I said that? Keep listening. Ask clarifying, relevant, open-ended questions. This lets them know you're engaged and listening. Stay curious, my favorite word, and interested in the speaker and everything he or she says. It's like they're the only person in the world. Respond to the speaker, acknowledge their feelings and what you heard. That, my friends, is the end of my presentation. I have some resources that I will send to APA, and these are just PDFs on how to become a better listener, and of course, my listening triangle. Moshe was a great teacher, no kidding. Here's a book. People always ask me, what's a good book on, you know, mediation or whatever? And Difficult Conversations is old. It's probably about, it's more than 10. It's more like I was reading this book when I first started, and it's at least 20 years old. And some Harvard project came up with this, and it's how to have everyday difficult conversations in work, with your family, with your kid. Really a great book, short book, like very short. So anything in this presentation can't be copied. It's copyrighted. There's my contact information. I included my final exit. If you need surrogate help, if you are a surrogate and you need help, you can reach me here. And that is it. I'm going to stop share. Are there questions?
Yes, we do. Fantastic job, Althea. Lots and lots of information. And
Too much.
yeah, and we all deal with it. So what you do is such a blessing and a benefit to all. So let's start with Bonnie. Bonnie has a question. She said, should this conciliation resolution be in writing, in written form, for family members or loved ones who cannot be present, to allow them to have a clear idea of the final decision?
You know, when you're the conciliator, you could probably have one of either a family member or a staff member take notes. And that's different than a formal agreement. So yes, I absolutely think that, because I'm, a visual person and I love to see a note or, some kind of something that tells me what the action plan is. And just like minutes in a meeting, okay, what's the action plan? Who is responsible for doing what? Naming which family member, which staff member. Because I said, you should really have a point person in each group so that, family know who they can ask the questions of. But yeah, definitely for the person that's out of town, instead of repeating the whole thing verbally, if you have a written note, you can send as an email. Yeah, this is what happened. That's another part of the whole confidentiality thing. Like I go to my grave with some of my mediations that I could tell you stories, but I can't tell you stories because it's confidential. But in this setting, everybody's trying to do the right thing. And I think that's a great way to, just keep people apprised of what happened at the meeting and what the next steps are.
Okay. Okay. So Rebecca has a great question. I do wonder how one would handle a physician who is biased or perhaps discriminating, i.e. mental health diagnosis that is underlying. So.
Well, I'm not really sure how, if it's a family meeting and now there's like one doctor in the room who's biased. I mean, it's a hard question to answer, but again, if you go back to the process, ask him to explain what he's talking about, what you think a mental health diagnosis is in order here. Why do you think that? You put it right back on them. Like what,
Right.
more like a doctor not taking a patient or family member's complaint seriously. Well, you can always change doctors. I mean, if you have a doctor that's really that blatantly not listening to a patient or what the patient wants, why would you keep that doctor? I don't understand. I mean, unless you're stuck with them for some reason, like you live in a rural area and he's the only one. But, you have your patient right is to have a doctor that will listen to you. Maybe call in a second doctor or a neurologist, somebody that may have information about the patient, about, like it's a hard question to answer like that. If I was in the moment, those are the things I might suggest. And really, again, family meetings are voluntary. You don't have to be there. But if you want the best care, you want to, do what they're asking you and make it some kind of decision. So I think you probably could, not just call in this one doctor. You could say, yeah, we'll be at the family meeting, but we want this other doctor too, or this nurse practitioner that she knows a lot about the patient and blah, blah, blah. So I wouldn't let them get away with it. Let me just say that, but that's just me.
So I've got a question. So in a situation where a patient's in the hospital and there is no other future treatments to be done in the hospital, and so the patient is stable enough to be transferred to the next level of care, the family doesn't want the patient to be transferred. And then the risk management legal team of the hospital gets involved. And basically it's a fight between the family and the hospital. So in the conciliation process of that, how do you, so you're the liaison between the two, you're communicating all communications, but there's still no resolution. So do you ever find a case where there's not going to be a resolution, and so then the courts have to take hold of it.
Yeah, well, that's why they have courts. And you could call for an ethics consult there. And I mean, why, when you say the next level of care, what exactly are you talking about? Comfort care?
Yeah, comfort care, for basically comfort care, the
Yeah,
patient's
okay.
terminal. So, but the family is not, they see, you know, all the records and the evidence that shows the level of illness that the patient has, and which we all need hope, but they are not wanting to take the advice of the hospital. And so it's, you know, turning into more of a larger ordeal. So,
well, you know, and I talked about trying something for a short time. And if it's terminal, do they have some sort of idea as to, you know, what the time frame is? You know, if the person has 6 months to live, these people are probably going to want to do everything until that time. But if the person only has, and if the doctors are honest about it, like, you know, this person is not going to come back from where they are, they're never going to have the same quality of life. And so you need to have a conversation with the family, I would think privately, because there's a lot of room in this for private conversations, and to educate them. Okay, this is, I mean, is there an advance directive? Did the patient want this? What, you know, have you had any conversations with this person? And really, it's like, you know, the guy in the hospital whose sister wants to do everything and whose daughter is saying, no, you know, stop it. He didn't want everything. And sometimes in a family, there's that person, but really you can have a situation where they'll go to court over it. And that's why hospitals are very reluctant to do anything if the whole family doesn't come on board with it. They want a consensus. And I've been in family meetings personally like that, where one person who didn't even know the patient, knew the patient, but didn't know what he wanted. 3 other people in the room knew he did not want to be on life support, and they default to life. They just do. And he didn't have an advance directive. He hadn't chosen a surrogate. And so they default to life. And so 5 years later, he's living exactly the way the neurologist said he would. He's alive, but he has no quality of life. It's so different than what he wanted. And so that's how one person, now they didn't go to court over it, but that's what happens in the real world in a hospital setting. They want all the family to agree because they don't want to get sued. And that's really the bottom line. But I mean, there's ways to talk to the people. Maybe they just don't trust the doctors that the person is really dying. Is there somebody else they could talk to that will, you know, kind of let them know, you know, this is what's going to happen. You know, 3 days from now, the organs are shutting down. Like, I mean, because when somebody's on a trajectory, they're on a trajectory down, not up. And if they can physically see, yeah, well, this person didn't lie to me, this person told the truth. One quick story, my minister moved to Arizona with her husband. They retired. He gets meningitis 5 seconds after they were here, goes into the ICU. Every doctor had a different opinion. Honest to God, her daughter named them like Disney dwarfs. Like, this one had this opinion and that one, and Grumpy was this. And finally, she said this young neurologist, a woman, came in. He was on, you know, all the tubes, everything. And she said to her, what would you do? Like, you know, is he ever going to come out of this? And she said, no, he's never going to be the same. He, you know, like, his brain basically is not going to function ever. He's, you know, maybe comfort care is what is best. So my friend gathered her whole family. She's a minister. She gathered her whole family. They sang hymns. They took him off life support, and he died peaceably. And she said she just loved that neurologist for telling her the truth, for saying. And so maybe that's what your family needs, you know, is someone to say, hey, he's never going to be the same, or he's not going to have the same function he had before. It's only going to go downhill from here, that kind of thing.
Right.
So
Right. Okay. Yeah, great advice, Althea, great information. Everyone, this will be posted on our website. You'll be able to review the presentation again. Althea's information is listed here. Please reach out to her. She's